All right. All right, everybody. It is Kelly, and I am here. I'm adjusting, I'm at the point in my career that I have two cameras now, which is crazy. So I'm adjusting that one for YouTube and this one for Instagram, and now I'm that person. And now I look YouTube in the eye, and now I look Instagram in the eye. Hello, all. So, welcome. Today is October live podcast recording. We are recording live, and I have so many questions that you guys have brought in and a tickle. So we'll take care of that first. Today, from the Q&A I put in my stories, the first question is, oh, Canada loves you. Dude, Canada does love me. Here's the deal. I'm an American, and I just checked my podcast stats, and 80% of my listeners are American, which means 20% is coming international, which is awesome. And Canada is 13% of that. So Canada totally does love me. It's very cool. And I love Canada. I literally only live 20 miles away from Canada. I would have to convert that into kilometers. But I call myself South Canadian. And actually, I grew up in northern Minnesota. So, the Canadians were all the hot dudes. The number one illegal immigrant in Minnesota is Canadian, apparently. I learned that a long time ago. I don't know if that's still true. But anyways, hello from Dr. Becky Lynn's office. Oh my gosh, awesome. Love Dr. Becky Lynn. Thanks for watching. So I want to give a shout out. I want to give a shout out to the women. It's a British group. It's a Facebook group. If you identify as a woman, you can join. And this group is called Vulvovaginal Atrophy. I literally think that that's what the group's called. There's 10,000 women in it, and I went live in that group yesterday. Smart as a whip. They know their stuff. They ask great questions. So shout out to the Vulvovaginal Atrophy Facebook group, and I will be posting that live recording on my podcast at some point. But shout out to them. And the other thing that I'm learning in this privileged space of being a doctor who talks to lots of people now that aren't doctors is over and over and over again, I see I went to my doctor and they blew me off. I went to my doctor and they blew me off. I went to my doctor and they said no. How do I ask my doctor to get on hormones? All this stuff. And it's not just sex med stuff, which I would think would be difficult enough, but it's menopause. For crying out loud, menopause is normal. It's normal. Menopause is not a disease state. It is normal. It is what happens when you live long enough. We can't not have it happen to us. And doctors are I had this lady yesterday, she's like, my doctor just told me, she went into her doctor for vulvovaginal atrophy, right? The new term for that's genital urinary symptoms of menopause, but that's an even worse Facebook group name. So keep your vulvovaginal atrophy Facebook name. So she goes in, talks to her doctor about vulvovaginal atrophy, and the doctor says, well, I can give you an antidepressant. And the lady's like, is it going to help? And the doctor's like, no, but you just might not care as much. And I'm like, she goes in complaining of vulvovaginal atrophy symptoms. And the option is legitimately, we have FDA approved medications for this. It's called vaginal estrogen, let alone just lubricants with hyaluronic acid and things that can help that aren't hormonal. And the option is an antidepressant. So I'm feeling, appreciating my privilege of never before seeing kind of the behind the scenes of what women have to go through when they go to the doctor. So that's enlightening. I'm not sure exactly what I'm going to do with all that information yet, but maybe I'll put it in my book. What's the role of vitamin D in menopause? Oh, it depends upon who you talk to. Some people think that vitamin D deficiency is very common and can lead to issues. Certainly we want normal amounts of vitamin D in our diet or in our supplements. But a lot too much vitamin D we don't think is healthy. But I haven't seen anything as far as it delays menopause or anything like that. I'm not exactly sure what you're asking. Two other people here. Ugh, hearing that just makes me want to vomit or cry. I think it was a cry emoji. And then I've been offered the same in response to vaginal problems. There's a problem with your vagina and the plan is an antidepressant? I can't even, you guys. I'm a doctor. I went to med school. And it's breaking my heart. breaking my heart, especially since like I literally joke that you cannot come and see me. Like you could probably come and see me if you have like a kidney stone or if you're a man with prostate issues, but you literally otherwise can't come and see me and leave my office without a prescription for vaginal estrogen cream. And I'm like, that is my bread and butter. It's what I do all the time, and I think it should be over the counter. Like that's how safe it is. That's how universally women benefit from it. You shouldn't have that barrier. First of all, the barrier of going to a doctor. Second of all, the barrier of a doctor not knowing what the hell they're doing, and they're not going to give you vaginal estrogen that actually solves the problem that you come in for. And it's super common, you guys. This isn't like a niche disease. This is like, first of all, I'm totally appreciating that this live October podcast recording is turning into like a rant, but genital urinary symptoms of menopause happen to 60 to 80% of women. It gets worse as you age. Oh my God. Okay. What are your thoughts about compounded vaginal estrogen versus vaginal estrogen that I can get at the pharmacy, other than compounding is very expensive? Good question. Number one, compounding can be more expensive. Number two, you don't always exactly know what you're going to get. That's the biggest problem with compounding, is it's not standardized. Do I hate compounded vaginal estrogen? No. But to me, I'm like, there's a pretty, in America, generic estradiol vaginal cream is now generic. If you go on the Good RX app, you can usually get a coupon, and it's awesome. So why not? I literally turn 50, get your mammogram, get your colonoscopy, and get your vaginal estrogen cream. It should be over the counter. You shouldn't have to go to a doctor, let alone a doctor who doesn't know what they're doing. After using vaginal estrogen for 3 months, my testosterone skyrocketed. Why? I don't know. Certainly that's not normal. Is it compounded? Might there be something else in it? Is it standardized? That shouldn't skyrocket your testosterone. I need to know more about that one. Especially if you're postmenopausal, your testosterone should be pretty low and not be skyrocketing. So I'd think, what else is going on? It's probably not your vaginal estrogen. Haven't seen it described. But the buck doesn't always stop with me. Like, I know a lot, but a lot of things I don't know. Should I check my mic? Oh, can you guys hear me now? Because somebody tried to call in, and that's why. Okay, so somebody tried to call in on my phone, and now my mic doesn't work. Here we go. We're going to end. And we're back. Okay, so what happens, I don't know if you guys know this, if you're going live on Instagram on your phone and somebody calls in, then it like messes up your audio, and then people can't hear you on Instagram live anymore. So that's what happened. So I just put on my airplane mode, so hopefully nobody can call me now and mess up your audio. That is the tech that I know as of these days. Other questions? I've been on hormone replacement therapy for 4 months, and my symptoms are returning. I'm not sure how much that can happen or not. I'll have to ask my friend Rachel Rubin on that. Hopefully she'll comment. I would just go back in and see what's going on. Repeating the answer on why your testosterone skyrocketed. I don't know. I'm not sure what else is going on. Testosterone shouldn't skyrocket postmenopausally because your ovaries aren't making testosterone unless something else is going on. I wonder if the vaginal estrogen is compounded and there's something else in there. I'm not sure. You're stumping me. Please let me know when you figure it out. Then I can let everybody else know. And then number 2 was hormone replacement therapy. What's the best hormone replacement therapy for hair loss? That's not a cut and dry answer. Hair loss is actually multifactorial. It's complicated. It can be thyroid issues. It can be genetics. It can be stress. It can be a skin condition. Hair loss is very tricky. So I would see I'd see a dermatologist who specializes in hair loss to run all the hormone panels and stuff like that, because just saying going on hormone replacement therapy to grow your hair back, I wish that was the case. But certainly a lot of people think their hair and nails are better when they're on menopausal hormones. But just to say to go on hormones for your hair loss, it's too much of a jump. It's too complicated. Hair loss is too complicated for things. Okay, so let's go to your other questions. This is what I want to talk to you guys about today. I want to talk about consent. So I'm seeing this a lot. I'm kind of seeing what's going to come out of this, but I keep hearing over and over and over from women that they have sex with their partner, stereotypically male partner. These are heterosexual relationships that are telling me this. Um, and they're consenting, so they're agreeing to a sexual advance, but they don't really want to, right? And they're agreeing so that something negative doesn't happen, right? Like that he won't get grumpy or he won't complain or he won't like go to bed mad or whatever the reason is. So you're agreeing to sex to prevent that negative outcome. You're not agreeing to sex because you actually want to have sex. And I've been toying and I actually looked up the definition of consent because I'm like, well, you're agreeing to it, right? But you're not really wanting sex, right? So what's the word for that? And my other thought is like, how does this actually affect a woman's desire and a woman's interest in sex and how her body responds to sexual touch, right? When you don't truly want to be having sex and you're just going through the motions. So to me, I'm super interested in this juicy topic right now. So I was looking up consent, and most definitions of consent are that you say yes to something, or you're agreeing to something. And the definition I really liked is consent is, I'm going to read it down here. Consent is when one person agrees to or gives permission to another person to do something. Consent means agreeing to an action based on your knowledge of what that action involves. Okay, you know what sex is. Its likely consequences, fair enough, and having the option of saying no. And I think that's where this piece of consent is really important for women who agree to sex for their heterosexual partner but don't actually want to be having sex, is they don't feel like they have an option of saying no, right? Because if they say no, then they have to deal with like all the consequences of saying no, and they're like tired to begin with. So what that creates, and I would love to see like stuff published on this or more conversations on this, because what you're creating is you're creating a woman who doesn't enjoy the sex she's having, and then she comes in to see me or whomever because she feels broken because her desire's gone, and she's been saying yes to sex that she hasn't really wanted to be doing, except for she just doesn't want the negative consequences of it. So in that definition of consent, having the option of saying no, I think you aren't consenting to sex, right? You're not giving full consent to that. Yeah, if you say, that's a dramatic example, right? If you say no, that you would end up in divorce. So you're having sex to keep the marriage together. So sex keeps the marriage together. But does that allow, like, that person should, and this, you guys, this is millions and millions of people. Like, this isn't like, you know, a unique thing. That person's enjoyment of sex, her feeling of agency, her feeling of like being an active and willing participant, right? I think that's part of that consent too, is are you willing to, or do you just not want to deal with the outcome of saying no? And I bet, this is all just my hypothesis, I bet if you talk to the male partner and you said, what happens when your wife says no, right? What do you think they'd say? Or if you say, when you ask your wife to have sex and she says yes, do you think it's a hell yes? Do you think she's enjoying it? Like, what's going on that other side of that, right? Or you're like, would you want to have sex with your partner if you knew it wasn't a hell yes? And how many people would be like, yeah, I just need to, whatever. So I'm super interested in this conversation. I think it's incredibly important, especially when we start talking about low desire and your own agency in sex and you enjoying sex. And it's like, having sex for pleasure is a hell of a lot different than having sex so you don't get a divorce, right? And it's not the sex that's the problem, it's that intent behind it. So I hope to do more on that work. I need to talk to more people. But feel free to DM me later about your thoughts on that, because I think it's incredibly important and it's a conversation that's not happening. Okay, so somebody asked Addie prescription, thoughts on effectiveness. So Addie is one of the 2 hypoactive sexual desire disorder drugs that is approved for premenopausal women only. Book is coming along. We need to talk about the book. I'll come to that after Addie. So Addie Works better than placebo. Remember, than placebo in sex works 40 to 60% of the time. So you give a woman a pill, you tell her it's going to make you have a desire. Guess what happens? She has a desire, even if she took a sugar pill. But it works better than placebo, which is why it got FDA approved. Doesn't work for everybody. Some people it does work for. Certainly, if you're having sex because you don't want to get a divorce, sorry to harp on that example, but it's like a dramatic example here. So if you're having sex because you are doing it so you don't get a divorce, and then you go to the doctor and you say, I have low desire. And then the doctor says, I don't know what to do. Here's Addie. It still hasn't changed your whole circumstance of what the heck you're. It's not going to make you desire, not, I won't say non-consensual sex, but like crappy sex, right? Non-engaged sex, non-pleasurable sex, all that stuff. So that's what I think about Addie is like, it can work for some people. The question is knowing who those people are. Because there's so much else going on, right? Like sex is considered biopsychosocial. And if Addie affects your neurotransmitters, so it's really affecting the bio, you still have that psychosocial going on that is super important. So if that's all clean and you just think, hey, maybe my neurotransmitters need a little bit of something and you're premenopausal and your insurance coverage is great and you want to take a pill every day, try Addie. But as you can see, I'm not like a raving fan. How's the book coming along? You guys, the book, round 2 of edits is, thank you for asking. First of all, it's very sweet of you. The first round of edits is, I printed it out, I bound it, because I have to edit like paperback. I can't edit on a computer. And it's underneath my coffee table in my living room. And I'm literally like doing everything else except for opening it. And I think what's coming up for me is a lot of perfectionist tendencies. So like, do I have everything in it that I want to have in it? Have I said everything properly? Have I done it to not piss anybody off? Am I addressing all the pain points, like all this perfectionist stuff? And like, there's something about it being on paper. Like Instagram Live and YouTube is one thing because it's like, it's today and whatever, I'll do another one. But like, it's like gonna be in paperback, right? Like, here's a book, Becoming Clearer by Lori Mintz. I'm super fangirling on her lately. Like, this is here forever. So, yeah, my editor's like, yeah, you're dealing with perfectionism right now, and that's a problem, and you need to work on it. And I was like, thank you. Thank you for the opportunity for personal growth. This is fantastic. So let's see. Here's the deal, guys. In order to be in my live video, you've got to be on the webinar part, because I keep that just for my email subscribers. And so get on email, and then you can be on my live video, and we can do some awesome sex coaching. Let's do some more questions. Okay, feeling sad. I've avoided sex for so long because of chronic UTIs and some allergies, and now I'm old. That's a question that I'm not giggling at this person. It's just, who's too old for sex? Like literally nobody is too old for sex. That's like what's so amazing about it. Society tells us that old people aren't sexual, so there's that. We got to work against that. But like literally, you're never too old to like feel pleasure in your body. We got to expand what sex is and what sexuality is and what enjoying pleasure is and what like feeling alive in our body is and like all this stuff, like, all the woo-woo people, like that's sex. That's you expressing sexuality in your life. And it's like, for somebody to be like, I had UTIs and now I'm too old. Like, are you going to wait for the next life to have sex? Because I'm not sure it's going to be there. What if in our next life we like don't reproduce, so we don't have sex? So point being, like, this is, as far as I know, and I can prove this is the only life we have right now. So if you want to have sex, have it. There's no such thing as too old. It just doesn't happen. Okay, next one. My wife has had a hysterectomy, and I'm looking for information about sex after a hysterectomy. And you found me through Dr. Malik. Awesome. Dr. Rena Malik is a urologist. Her big platform is YouTube. My little platform is YouTube. I have a very little YouTube platform. And her target is men. She does a lot of urology general education. So shout out to Dr. Malik. So he found me through there. And his question is sex after a hysterectomy. So there's so much that that's in that question, right? Like, is your identity as a female changed? Did they take your ovaries? So now we're dealing with hormone stuff. Is there scar tissue, maybe lack of vaginal length that is causing issues with sex? By and large, and I hate to stereotype, but I want to say there are many hysterectomies happen all the time, and many people have no issue with sex whatsoever after it. So if you are having issues with sex after a hysterectomy, I worry, what's going on. I certainly would want to do a physical exam. I certainly would want to talk about hormones, check hormones, see what's going on with hormones. Body image certainly can change after any surgery, right? So I would think about that. Those are my thoughts off the top of my head on sex after hysterectomy. Okay. Next one. Help, I am 50 years old and have been going through menopause for over a year. Weight gain, brain fog, night sweats, hot flashes, all the stuff. Are hormones safe for now than they were when my mom took them 20 plus years ago? Yeah, I would think so. You can certainly, there's a lot lower doses that you could start on, right? A lot of these medications have been around for a long time. They're pretty well tested. The other nice thing about medications being around for a long time is they're cheap, because we get to be on hormones for as long as they're working for us now. There's no like you have to stop at a certain time anymore, like they used to say. If I get on hormones, will that help with the weight loss? I'm on a pretty clean diet and exercise 5 days a week. First of all, good for you exercising 5 days a week. Exercise is the single best thing you can do for yourself. Number one in general, number two with menopause, number three for sexual function. I'm reading this, Menopause Practice, a Clinician's Guide, 6th edition, from the North American Menopause Society. Here for the Instagrammers. There you go. I'm going through this. I actually have a book club on this, or a journal club, like once a week right now, because I'm taking this test end of October, to become a NAMS, North American Menopause Society certified practitioner. I don't know, I might fail the test because I'm a urologist and a lot of this is like general medicine stuff. It's okay. They can have my money, my donation, but I just want the knowledge of hormones. So point being, it comes back time and time again to exercise, 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 exercise. Bone health, cardiovascular health, brain health, preventing weight gain, preventing insulin resistance, preventing depression. Great for sleep. It's good for sex. I just gave you 8 off the top of my head reasons that movement is good. Big myth on movement. People just wait around to get motivated to exercise. Like, there's no motivation that's going to come. You just do it. It's kind of like spontaneous desire, right? Like, spontaneous desire may or may not actually be a thing. You want to have sex? Go have sex that you enjoy. You want to exercise? Go do exercise that you enjoy, right? If you do exercise because you're preventing a divorce, you might not like it as much. Just saying. Okay. So the point of that whole thing is, if I get on hormones, will that help with weight gain? Maybe. Right? We don't think that menopause is an independent risk factor for diabetes, but certainly being on hormones can help insulin resistance. Oh, Jill Kraft is on here. Jill, I literally was just showing them this menopause practice book and talking about our journal, our book club that we do every Monday night. Dr. Kraft is taking the menopause book too, or menopause test too. She'll probably pass. She's brilliant. So yeah, that's what I would do to answer that question. Okay, next one. This is more of like a general urology stress incontinence one. So, hi Dr. C, thanks so much for your podcast. I'm a practicing PA interested in women's health and also sitting to sit for the NAM certification. Look at you, that's awesome. Okay, I have a question about some of the boutique options I see being offered to women as an alternative to surgical intervention in regards to stress incontinence. So stress incontinence is leakage of urine with cough, sneeze, and laugh. After pelvic floor PT, if a patient continues to experience symptoms, I tend to think of surgery. With the FemLift lasers and older Mona Lisa, should I give those treatments more weight? I would say no. They're expensive. They're not covered by insurance. They're not FDA approved for incontinence. I think lasers work very, very well for dryness, atrophy. It helps bring in collagen and blood flow. Yes, they can help both overactive bladder and stress incontinence, but at like $3,000 a pop with the need to redo it over time because the gains aren't permanent. It's your most expensive option for stress incontinence, and it's not FDA approved. So no, I wouldn't give those treatments more weight than you are. She says they're expensive, not super definitive, and I'm guessing would need to be maintained. Yeah, exactly. Once a mesh is in place, is a person no longer a candidate for a vaginal laser? No, it's fine. As long as vaginal lasers are very, very superficial, and a mesh certainly is a lot deeper in the pelvis. It's between the urethra and between the vagina and the bladder, right? So certainly that's a lot deeper than where the laser is going to penetrate. Lasers penetrate very, very thin, right? Just the external, if you think like the skin layer of the vagina is where the lasers penetrate. Dr. Streech is here. Oh my gosh, I'm amongst an expert in menopause. Thank you for being here. Thanks for joining me. I love your stuff. Keep doing what you're doing. I was a neuroscience undergrad, if that impresses you at all. I got away from the brain to go into urology, and then like through life coaching and like sex med, I'm way back up in the brain again. So here we go. Yes, thank you for saying that. Depth of a credit card for lasers. So once you have a sling in, or an older prolapse mesh, if you were in there, yes, you can absolutely have lasers. Ideally, you're not going to have a mesh erosion and laser that, but that's pretty rare, and your correct practitioner should know what that is. So yeah, you can have a sling, and then you can have lasers afterwards for dryness, tightness, stuff like that. My personal opinion is anybody who's had mesh in their pelvis for stress incontinence, or even has just had prolapse without mesh, I think vaginal estrogen for life. Number one, I think that in everybody, but number two, it just helps keep that tissue healthy, helps keep it plump and thick, because if that thins, you're going to be all the more prone to a mesh erosion, or pain with scar tissue and stuff like that. So that is my plug. How many times can I plug vaginal estrogen in one podcast? We don't know, but I'll keep trying. Okay, here we go. I know you recommended a lube, and I can't find where I saved the name. I probably recommended Uberlube because I'm not sponsored by Uberlube currently, but Uberlube is cheap, it's clean, it doesn't have a lot of crap in it, it's silicone, which I love because it's long acting. Meaning if you have really dry postmenopausal skin, it is great. It won't just get sucked up like a water-based lubricant is going to get sucked up. I think it also feels better than some tacky water-based lubricants. I think KY jelly is like the Kmart of lube. I'm like, ugh, you need to do better. So silicone-based is really nice for me. They always say you can't use it on silicone toys, but like, I am. So my silicone toys are still intact. I think someday they're going to be like, turns out you can. But, if you have nice, expensive silicone toys, maybe you don't want to mess with using silicone lubes. But then you have to have 2 lubes. Oh well, it could be worse. I'm 57 and I'm on a compounded estrogen and testosterone and a troche, as well as progesterone with DHEA and a compounded capsule that I take at night. I'm wondering if there is something more cost-friendly. Yeah, I only, if you want, share with us how much you're spending a month on that combination. First of all, DHEA is touted by a lot of kind of health and longevity people. The data, if you were just want to go by data, yeah, KY is poison, high osmolality, and eats tissue. Exactly. It's Kmart of lube. Don't use it. There's so many great lubes too, you guys. If you just go to, if you have the great pleasure of having a wonderful woman-owned boutique sex shop in your town, like I do, they'll have a nice wall of lube, and they have samples, and you can try them. I always just recommend no color, no smell, no flavor, the warming stuff can be irritating for people, but that's fun play stuff. You just want clean, doesn't irritate sensitive dry skin, lasts long enough for you to have pleasure and orgasm. Use lube. You can have sex without lube, but why would you want to? I can just see my virtual assistant is gonna take that as my quote from this podcast. It's why would you want to? DHEA, not any great data to say that it does anything for you. Certainly it might cause harm. It might convert into estrogen or testosterone and give you more issues because you're already on those things. Testosterone topical in the male, it's for men, right? But you get it and you dose it for women, which is 1/10 the dose. It's dirt cheap, right? This is text in here if you'd be willing to tell us how much you're spending on that, because I'm convinced women drop an arm. Menopause, average lifespan's 84 years. Menopause starts at age 50. You're looking at 40 years of hormones, okay? So add up your monthly cost, multiply that by 40, and see if you actually want to be spending what you're spending on this. So that's my thought of that. KY is poison. I love it. I'm going to make that as your quote for this podcast. Okay, so next one. Oh, yeah. Okay, so that was recommendation for lube. After the third time of ripping after sex, I know I need some. And you're 51. Okay, number one, lube. Number two, probably get evaluated for vaginal estrogen because you're probably having some menopausal atrophy going on. We gotta fix that, because if you keep ripping during sex, you're not gonna want to have sex anymore. Like, literally, you guys. Menopausal, top two reasons that women after menopause stop having sex. Number one, availability of partner. That makes sense. Number two, menopause symptoms. So we treat the menopause so you can continue to have sex, right? So for you, I'd say silicone lube, vaginal estrogen. Just to clarify on that, you don't use the vaginal estrogen during penetrative intercourse with a penis. It's for skin care, not related to the actual sexual event. Lube during the sexual event. So there you go. Can BRCA2 women use hormones after risk-reducing surgery? I would say this. Everything's individualized. Talk to your practitioner. You want to see a hormone specialist. There's always risks and benefits. But if you read the book Estrogen Matters, do I have that around? No, I lent my Estrogen Matters to my PA right now. If you read the book Estrogen Matters, he actually does talk about that. And we do believe that you can be on hormone replacement therapy, and people do quite well with it. So, yay, Dr. Stretch agrees. So yes, but I think so many women are just so freaked out about hormones, right? So it's like, you gotta, like, I have one lady right now who's like so freaked out about hormones, and she has osteoporosis. Oh, Dr. Starch has a book, Hot Flash Hell. Nice. You want to come on my podcast? I'll read your book, and you want to come on my podcast? Let's talk after this. I'm spending about $100 a month on the Troche and the progesterone DHEA capsules, so just 2 compounded prescriptions that cost me $100 each month. Okay, so $200 a month, not crazy. People spend thousands, right? But everybody's situation is different. So $200 a month times 12, $2,400 a year. If you love it, if it's working for you, like, I'm not going to tell you to try to find something cheaper, but if you do the FDA approved Testum male formulation divided by 10, you're looking at a 300-day supply for about $140. So I just dropped your cost by a factor of 10. You're welcome. So, FDA approved and cheaper. It's compounded shit. It's making somebody money. It's not making you money. It's not making me money. Let's go spend our money doing something else. Spend it on nice lube. Okay, let's see what else we can do. When you say to use topical estrogen as a suggestion on the vulva, does bioidentical work? Streecher. Dr. Streecher is your actual name. Good to know. And the book is called Hot Flash Hell. We'll talk later. Awesome. When you say to use topical estrogen as a suggestion on the vulva, does bioidentical work? Yes, estradiol cream, FDA approved estradiol cream is bioidentical, you guys. Don't think bioidentical is this like sexy, amazing thing. It's marketing. Like, there's FDA approved products that are bioidentical. My doctor acts like she has no idea what I'm talking about, but the dryness and chapped feeling is bad. Well, if you listen to the earlier part of this podcast or Instagram feed, we're telling women, like, the doctors are like telling people to go on antidepressants for this, which is ridiculous. So the snarky me is like, have you tried an antidepressant for your vaginal dryness? Because it won't work. But women have been offered that. Okay, so listen, bioidenticals, like, it's just a marketing term. It's like putting natural on a candy bar. Like, that's the equivalent. So I would go to your doctor. I would not use the term bioidentical, because doctors know that when you say that, you have no idea what you're saying or asking for, because it's just been fed to you. Anyways, so go to your doctor and be like, hey, I hear it's totally standard to be on low-dose vaginal estrogen cream to prevent genital urinary symptoms of menopause. Can I try a prescription? Boom. That's it. I love you guys so much. Here we go. Is anyone here, this is the next question, is anyone here single and dating? I'm thinking about it, but honestly, for the first time in my life, I'm daunted by the idea of intercourse. I'm postmenopausal and have been celibate for several years. I know sexual intercourse will be awkward and painful, hopefully, but not for so long if I ever do get a boyfriend, since my libido is so low. Libido is different than sexual intercourse being awkward and painful. They're like not even related things. Like they're not even in the same room. Libido is your desire or interest or sex drive, right? Thinking sex is going to be awkward is just a mindset and a limiting belief. Sex being painful has nothing to do with libido either. So let's break all those apart. I'm finding my fears about sex getting in the way of even considering dating. Totally common, you guys. Totally common. God bless. Absolutely. I totally get that. Anyone else here facing that kind of thing? I would say yes. That's a very common thing. Anyone overcome it? I would say many people overcome that. I've ordered some toys. Good for you. But my motivation to use them is low. Well, you bought them. Isn't that curious? I appreciate being able to bring this up here. Thank you for bringing this up. It's a great question. So my question would be, what kind of sex do you want to have? What does having a boyfriend mean? Does having a boyfriend mean the boyfriend's going to put the penis in the vagina? What if the boyfriend's penis doesn't work? It's entirely possible. What if you have a boyfriend that doesn't want to have sex and you don't want to have sex? Then you guys were like, thank God you found each other because life's better. But you didn't go meet him because you were worried about that, right? So many things to unpack. You're going to do great. People do great. But think about what you want, what kind of sexual being you want to be, all of that stuff. Because if you just think, oh, in order to have a boyfriend or a man, I need to X, Y, and Z, it's gonna put you in a whole different headspace than if you're like, I'm going to go see who I can meet because I'm curious about it. And then when we talk about sex, we'll talk about what I want for sex because I've figured it out ahead of time instead of just like fearing that whole thing the whole time. Certainly, here's the other thing about consent, right? Before you get to that naked, vulnerable, I found this new toy I love and I love it and I want you to try it. Talk about sex while you have clothes on before you have sex, right? We don't get taught that, you guys. Like only right now are we actually ever teaching men and women and all humans about consent and discussing sex before you have sex. And I tell you, the fear of talking about sex is way worse than the actual talking about sex. It's not that bad. Like once you're done, you're like, I didn't die. I totally thought I was gonna die, but I didn't die. So that's nice. So much love to this woman. It's a great question. So many people have the same question. But just breaking apart all those different things, right? Like libido isn't pain, isn't fear, isn't it, dating doesn't mean the penis has to go in the vagina. So many different things, right? So I guarantee you there's a man out there who doesn't want to date because he's worried that his penis isn't going to work. And he's preventing himself from meeting a, wonderful human because of his fear. So this certainly by no means is like a woman alone thing. So much love. You guys, should we do one more? I have so many. Like, it's like, you can't see all this, but like, look at all these that we're going to hold till November. Oh my God. Okay, let's do one more. Intercourse isn't really the issue for me. Dating at age 50 is just ridiculous for a host of other reasons. It's hard when you're strong and capable and independent. I also carry a few extra pounds, which means I'm undateable. It's seriously crazy. Please help. Okay, that is common, totally common. I would very much, how much have we talked, you guys, about limiting beliefs, right? Being overweight and dating and being undateable is a limiting belief. There are plenty of people who like people who look the way you look. Guarantee it. There's so many people in this planet, you just gotta find your people. You gotta find the people who love you. But your limiting belief of I'm undateable, I'm unlovable because of my weight, that's what's holding you back. Not this fact that you think exists that nobody would want to date you, right? That's where your work is. Your work isn't in the losing weight. Your work is in the accepting myself as I am, knowing there's somebody out there who wants to date you and going to go find that person, right? Because if you're just sitting there, look, basically finding validation for all the thoughts you have in your head, you're not going to get anywhere. So check your limiting beliefs. We have so many limiting beliefs about sex, like it's not even funny, right? Like, sex should be easy. Sex shouldn't be hard. I shouldn't have to talk about sex. Just because my relationship's good, my sex life should be good. Sex is natural. All of this stuff, right? So, all right, let's see if we can do a little bit more, and then I'll do one more because I love it. Do you like the estrogen ring? And if you have a chronic UTI, will the ring cause more sensation of frequency? It shouldn't. It really shouldn't cause more sensation of frequency. If you already have a lot of atrophy, you might feel it a little bit more, meaning it might just aggravate it a little bit until it gets healed. I do love the ring. I think it's plug and play. Every 3 months, use it and forget it. It tends to be a little bit more expensive. So, that might be a thing. But I tell people this, like, if your estrogen cream or ring or tablet prevents one urinary tract infection, it's already started to pay for itself. This is preventative medicine. So I say give it a try. Try it for 3 months. If you hate it, try something else. That's what's so great about hormones, you guys. Try them, adjust them, fiddle with it, ask questions. It's not like, I think so many women that are just like, should I be on hormones? Should I not? Like, it's like this cliff dive or something like that. It's like, try it, see if you like it, but give it some time, right? The body does need to take time to adjust. Just to clarify that on vaginal estrogen, it does take about 6 to 8 weeks for it to kick in for a lot of people, sometimes longer, a lot of times sooner. But like I see so many, Rachel Rubin, Dr. Rubin, I love her. She says nobody fails vaginal estrogen. Like, you just didn't try it long enough, or the dose wasn't right for you, all of that stuff. So give it some time, but like, try it, troubleshoot it, stop it if you don't like it. As a BRCA2 person who's had all the problem areas removed, I got all clear to try HRT. Woohoo! Very, very, very awesome. Okay. Oh, thank you so much. You're a wealth of info and really love your podcast. Thank you. I'm so glad that there's like a group of women who like my feistiness, and it actually like comes across lovingly on social media. I'm 64. I've had estradiol patch, but I've never heard of estrogen cream until you spoke about it. Now I want it. Yeah. Even women who are on hormone replacement therapy still can benefit a lot by vaginal, because remember, hormone replacement therapy is still so low. It's not often enough to get into the vulva and vaginal tissues. So doing both systemic and vaginal is very, very common. Lots and lots and lots of people on that. You're allowed to do that. Don't let any doctor tell you you're not allowed to do that. And give it a try. See if you like it. Give it 3 months. Report back. All right. Love you. Thank you guys for the podcast. 80% of the podcast listeners are American. That means 20% is international. 13% of it's from Canada. So thank you. Thank you, Canada. I love seeing international listeners too. It warms my heart. All right, you guys. Until next time, I love you so much. And remember, you are not broke.